A warm welcome, ladies and gentlemen, to day number 3 of TIO 2021. And we are starting this day with the Satellite Symposium, which deals with the topic of streamlining TAVI, how to deliver best patient outcomes and efficient pathways. This symposium is supported by Medtronic. My name is Mohammed Abdel Wahab from Leipzig, and I'm joined by an excellent panel, which includes Kendra Grupp from Atlanta, Chris Malkin from Leeds, and Stefan Tockweiler from Luzern, who is going to join us in a few minutes. He has some technical issues. And the objectives, as you've seen in the introductory video of this symposium, are actually focusing on patient management pathways in the current era of transcatheter aortic valve interventions. As you might know, we gained a lot of experience in the past 15 years with this revolutionary procedure, and the volume of interventions have now exceeded the volume of surgical procedures in the vast majority of Western countries. And because of that, we are dealing now with a relatively new challenge, which is how to deal with this expanding volume of patients in an efficient, but also in a very safe pathway. And this is why the objectives of the symposium will be to discuss patient management pathways and considerations for TAVI. We will discuss a little bit about how to best utilize the available resources and improve procedural efficiencies. And we will review a couple of cases that highlight these procedural management and efficiency considerations. We will change the order of presentations a little bit because, as mentioned, these few technical issues Stefan currently has. And we will start with a very important presentation from Chris Malkin from Leeds, who's going to discuss procedural considerations for better patient outcomes. And I would like to encourage you to ask your questions through the chat function, and we will, of course, pay attention and discuss these between the different presentations. Chris, the floor is yours.
Thank you very much, Mohammed, for that generous introduction. I'm delighted to contribute to this presentation today. So I've been asked really to confine my comments to the procedure. Of course, the procedure is only really a part of the pathway. In terms of time, it's an hour or so. There's obviously a lot of work and thought that is required to select and get the patient to that position. I have some disclosures of interest which I will present there. So this is a photograph of a case that we did in my centre a week ago. And what you see is the absence of lots of things that were there perhaps 10 years ago. This is a standard cath lab. It's not a true hybrid. There's no anaesthetist. There's very little extra equipment. It's a default minimalist approach. My fellow Jordan is accessing the left radial. That will be the Marker pigtail. And it's a single large groin access to deliver the valve and avoiding groin access where possible. There is safety built in. There is a clear plan. There is safety equipment. And at the foot of the bed is a bespoke procedural plan which is crafted for that patient. It's got precise details of the medical history, an escalation plan, predicted problems, equipment that will be required, detailed assessments of the anatomy and hemodynamics. And any operator can walk in and read that plan and know exactly what is going on for the procedure that day. Going single groin access makes it very important to be extremely skilled with vascular access and particularly with ultrasound. Ultrasound for every groin access and even ultrasound for accessing the radial if it's difficult. We found that we were getting complications even from small sheath access from the groin, not life-threatening complications, but there's been a marked reduction in hematomas and things that just mean a patient has to stay in a day longer by avoiding as much groin access as possible. And we have found that you can actually use the vascular access from the radial to save any real need to access the other groin. You can get down from the leg very easily. A month ago, we did have an occlusive dissection in the large vascular access, which we were able to deal with purely from the radial by delivering a guide catheter and crossing with a selection of wires. You need to plan for that. You need to have all the radial equipment and bailout equipment in a defined area, but it is available, and it has saved us having to puncture the other leg or calling for vascular assistance or surgery on multiple occasions. Sorry, it's a bit slow here. The key part of the procedure, I guess, is the vascular access and obviously implanting the valve. I think this photograph shows a really important factor, which I think has evolved in the last few years. And I think we learnt this actually when we started to use the Portico system, which is more flexible. There's this cross-handed implant with the first operator controlling the delivery catheter with their left hand and the wire with the right hand. And that just gives better biological feedback from one operator controlling both parts of the delivery system. And the second operator has their hands purely on the release mechanism of whichever valve. I think that really does allow the first operator to precisely deliver the valve to the exact location. It's important that everyone knows what they're going for, but I think this is the way that I have adopted and that I teach valve implantation. And I do think it's really important to try and deliver the valve to the correct position the first time. I don't think repositioning, even if that's an option, is a benign thing to do. And I make every effort to make sure that the valve's in the right position the first time. So everyone agrees where you're aiming, you maximise the fluoroscopic projection, and you implant on a short burst of fast pacing, often with a puff of contrast. Avoiding groin access means not putting a temporary wire in the right ventricular apex. We've adopted a policy of standard LV wire pacing, which is becoming increasingly prevalent. We found an additional safety step, as you can see in the focused and left panel, is actually to put a micropuncture wire into the femoral vein. That almost guarantees that you get capture of the ventricle for pacing. But it also means that if you're unlucky enough to develop a period of substantial heart block, for which you do feel you need to escalate to a temporary wire, you've actually already got easy access to the femoral vein. You can simply insert a 6 French radial sheath and implant a temporary wire with minimal fuss. And that builds in some safety. The fact that we're putting in much fewer temporary wires essentially means the patient can get out of bed and mobilise. And our standard policy is to set people out and have them on their feet at 4 hours if the groin is uncomplicated. We will do a 12-lead ECG on arrival after the TAVI. If the ECG is plumb normal, we do not telemeter them beyond that, and it's possible that those patients will go home the same day. As soon as there is 24 hours of ECG stability, we will let the patient go home, and the median day of discharge in our centre is within 2 days now, with many patients going home at 24 hours. There are some exceptions. If there is a right bundle branch block or obviously higher degrees of block, and I think in patients who are critically ill, I think having fine beat-to-beat control of pacing is probably more important. On those occasions, we will implant a temporary wire for the purposes of the procedure. Moving on to slightly more esoteric and innovative concepts, we've adopted in the last 18 months a policy of implanting in a two-cusp overlap view. I do think this is quite important. It's a way to minimise the risk of conduction disturbance. And in reality, what it is using the fluoroscopy to maximise your appreciation of the left ventricular outflow tract. So if you compare the same anatomy just in two different projections here On the left, a coplanar view. On the right, a two-cusp implant view. This view maximizes the ability for you to perceive the LVA outflow tract in a one-to-one appreciation. And if you just use this diagram here, in the right upper panel is an overlap view. The LVOT is actually foreshortened very significantly. And the ariocaudal view, the LVOT is significantly elongated. And if you implant in that view, in the ariocaudal view, then your appreciation of what, say, 2 millimeters or 3 millimeters is more realistic. I would advise implanting in the ariocaudal overlap view based on your CT predictions. And you can aim high safely, and that minimizes the risk of bundle branch block and AV block. I think you do need to get into the habit of checking the non-coronary side in the ariocaudal view and then swinging over towards the LEO projection to check the left side. We've learnt that the two views are required to check the two sides of the valve. You can't do the whole valve in just one view. You need two views to assess this. And this has allowed us to aim higher, and our pacing rates have dropped about 3 or 4% from around 13 to 9% in the last 6 months. The last thing I wanted to mention was trying to implant valves in a commissure to commissure fashion. So obviously surgeons do this all the time, and for some of our valves, the shorter valves, the balloon expanding valves, having the commissures is probably less important, but it is more important, I think, for the taller valves, and particularly the superannular valves, such as the Medtronic platform, that we do try and do this. If you are unlucky enough to implant the valve with the TAVI commissures opposing the coronaries, that does have important implications down the line. It might make it difficult to reaccess the coronaries for PCI, and it may make the option for redo TAVI in the case of degeneration impossible. But there are ways that you can implant these valves such that you maximize your chances of getting commissure to commissure implantation. This is a slightly busy slide, but there is a relationship between the C paddle, the C tab, which you see on this released valve here. That C tab is always at 90 degrees from the hat marker of the evolute system. So if you know where the hat marker is, you know where one of the commissures is. And as long as you reference the anatomy of the valve to how you're implanting your evolute valve, then you can really not guarantee, but certainly significantly increase your chances of getting commissure to commissure implantation. There are some very, very simple things that you can do. This is the evolute platform, and if you simply insert the catheter with the flush port at 3 o'clock, as you see here on the left side, then you're already more than doubling your chances of getting the commissure to commissure implantation. The other things that you can check in a PA or slightly LAO projection on PA, that the hat marker is on the greater curve of the aorta as it goes round the descending and then to the ascending part of the aorta, you're very likely to have achieved it. Our practice is to try to get the hat marker on the greater curve. Once the valve is around into the annulus, I don't believe it's safe to do major changes of the alignment. But if you do just these simple maneuvers, you double your chances of getting commissure to commissure alignment. So I've rushed through a little bit, but I think some of this is philosophy and some of it is building in safety to a simple approach. I strongly believe that really all procedures, no matter how risk, can be done with a minimalist approach with no sacrifice of safety. In fact, probably a higher degree of safety. I think there are things that we have done in the past that are not helpful and potentially increase risk. The most important thing is to have an absolutely bespoke, a clear plan for every patient so that everyone in the room knows what the plan is. You can build in the safety. So I talked about having the radial bailout kit. in our lab, we have a trolley or a cart with all of the kit on that we could possibly need if we need to control for a bleed in the leg or for a occlusive dissection. The key parts of the procedure are the same, and you should take your time and maximize your chance of doing it first time accurately. So vascular access, really skilled ultrasound micropuncture, valve implant, get it in the right position the first time, make sure that you're in the correct projection, do it on pacing, and you can avoid the need to reposition. And finally, vascular closure, make sure that this is done accurately and don't leave the lab until you're completely satisfied that the leg is safe. That's my final slide, and thank you very much for listening. I hope you enjoy the rest of the presentations.
Thank you, Chris. So this was a wonderful presentation on current procedural aspects that I think, all in all, are important and clearly underline how the procedure has evolved now to become a very standard procedure, but also with a lot of refinements that we learned in the last few years in order to improve not only procedure, but also long-term outcomes. But let me maybe ask you one question, and then we go to the panel discussion. I hope that Stefan has now joined us as well. You showed on your first slide that you modified a lot of things probably throughout the years, and I think this is probably an evolving process. So you skip one thing, and then you skip another thing, and then you. But were there any things throughout this journey where you thought, okay, this was a bad idea to skip, and you made a U-turn probably, or changed your mind, or is this a process that was like always evolving in a positive manner?
The only thing that we ever did that we came back from, I think, was for the LV wire pacing. We initially adopted that by putting a needle into the skin and clipping onto the needle. And this seemed to work very well, but we had one case where the patient was fragile and the patient went on to develop heart block during a period of hypotension, and it was a scary moment as we tried to rapidly puncture the vein to get a temporary wire in. So we then evolved this, putting the micropuncture wire into the femoral vein and even having the wire going just up into the cava so that the vein was already pre-accessed. There's almost negligible risk to having a micropuncture wire in the femoral vein, and it means that if you need to give drugs through a big sheath, you can put the sheath in, and it means that if you need to escalate to a temporary wire, you can do so very quickly. So I think that's the only example where we went completely minimalist and then came back a little bit, but it felt like the coming back to a micropuncture wire in the vein was a very small step, and it's just something that we feel is just builds in a bit more safety.
Yeah, I think this is a very important point. So you need to be, of course, courageous in making a step forward and trying to improve procedural efficacy. And streamlining your procedure, but you also need to be courageous to make the decision when this would affect safety. So Kendra, tell me a little bit about your experience with streamlining the procedure overall. And I've came across a very interesting paper from your group yesterday, which is looked at procedure efficiency in the current pandemic situation. And I think you analyzed your experience with same-day discharge. Tell us about your thoughts about which procedures do you consider to be suitable for such an approach?
Sure. So we were already a very lean TAVI center, a minimalist pathway, fast track, whatever you want to call it. We used nurse-led sedation, and we had a discharge pathway where the patients would be discharged first thing the following morning after their procedure. Well, once COVID started, we had two competing problems. One, patients did not want to come and spend a night in the hospital, and we had a restriction on our beds. So in order to be able to treat our patients who are developing heart failure and get them through the process faster, the same-day discharge pathway was just the next evolution of our already minimalist pathway. And so basically, you know, the first 2 patients in the morning are eligible for same-day discharge. We did have a protocol that was an evolution of our already fast-track protocol. So patients needed to have an ejection fraction above 35%. And they needed to be less than 90 years old. They needed to be able to ambulate within 4 hours of their procedure. And they needed to be basically straightforward transfemoral conscious sedation patients who were eligible for nurse-led sedation. And if they met all of those criteria, and excuse me, one other is that we excluded super morbidly obese patients. If they met all of those criteria, then they were eligible for that pathway. If their procedure went without complication, then they could be discharged within 4 hours of their, 6 hours of their procedure.
Okay, great. I mean, this highlights a little bit what Stefan is going to talk about in the next presentation, that it's not only the procedure, but it's also a whole process that starts with patient preparation and evolves throughout the procedure and ends up, of course, with post-procedural care. So the what we used to call the minimalist TAVI approach, I think Stefan is calling lean TAVI, and I'm happy to introduce him, and we're very happy that you could join us, Stefan, and tell us about your experience with the lean TAVI concept.
All right, thanks, Mohammed, and thanks for the whole group for this kind introduction. I would like to present you our lean TAVI concept. It actually goes beyond the minimalist pathway, which we're probably all using, as you will see. So these are my disclosures. So just to give you some background information, of course, the hospital organization is very complex because there are many highly specialized units. They have to work together under the same roof. They share sometimes the same resources, but actually they function on a completely different level. So oncology and cardiology really doesn't have much in common, but it's still in the same hospital. And therefore, the TAVI program, which is also embedded in this complex system, is also quite complicated. And if you look at all the stakeholders that are involved in the TAVI program, you can imagine if you change a TAVI patient pathway, it can be quite challenging. I just list a few stakeholders here. Maybe there are more, but if you count, you come easily to 15 different stakeholders that are somehow involved in this program. Therefore, again, because of this complex stakeholder engagement, changing a TAVI pathway is challenging. And I think one of the most one of the highest hurdles is actually the historical barriers. So very often you hear people say, yeah, you know, we have always done it like this, or it works like that, and it's fine, and so on. So because of that, it's really quite a challenge to change a program, and usually you need a strong clinical need. And this strong clinical need, of course, can be COVID-19. So we implemented our lean TAVI program a little bit earlier because we were facing a reduction in ICU and anesthesia capacity in October 19 and January 20. I don't want to go into details here, but we had to come up with a solution on how to continue our TAVI program. And of course, then in March 2020, we had COVID-19, and soon thereafter, there was the first lockdown. So the goal of the lean TAVI program is to perform TAVI without anesthesia in the room and without using an intensive care or intermediate care unit. We also enable same-day admission. Of course, we encourage early discharge. I mean, if you can do same-day discharge, I think it depends a bit on the hospital and on the patient, as has been pointed out. But of course, you want to minimize hospital stay. And then short transport routes or no transport routes at all, and minimize the risk for nosocomial infection and resource utilization. Now, of course, if you do this concept, you still want to have anesthesia and ICU as a backup available. So you need some friends in the hospital. That's very important. So if you want to establish a program, you have to get anesthesia and ICU involved, although they will not be part of clinical routine. And I think it's also important to monitor outcomes of a lean TAVI program, as safety is the most important aspect and will remain the most important aspect. So this is a summary of the lean and the minimalist TAVI pathway. So again, with the lean TAVI pathway, same day admission, no anesthesia, monitoring the patient just outside the cath lab. And then the patient goes to the ward and stays 2 nights usually. This is also foreseen in our DRG. If you do same day discharge or next day discharge, you actually get a penalty, and it's financially not attractive. And I personally think that the patient still can have arrhythmia. It doesn't have to be heart block. It can also be atrial fibrillation, which is previously unknown. So it actually, I think keeping the patient 1 or 2 nights is actually not a bad thing. This is a visualization of patient transport routes with a standard TAVI pathway in red and the lean TAVI pathway in blue. And you can see how much easier this is in our hospital, how much easier it is for the patient. The patient is directly admitted to 2nd floor, which is the cath lab and also the area outside the cath lab, and stays there the whole day. And also the team does not change. So the patient will not see like 20 different people. He will see maybe 10 different people for the whole day. And then the patient goes to the ward and only comes back for a transthoracic echo before he's discharged. Here you can see a visualization of duration of hospitalization for the first 50 lean versus the first 50 minimalistic TAVI patients, and you can already see a reduction in the duration of hospitalization. Of course, some patients still need longer if you have a complication or you need a pacemaker and so on. And this is the concept of lean TAVI. We have 2 physicians at the table, and then we have 4 nurses in the cath lab. 1 is at the table helping with the procedure. 1 is crimping the valve. 1 is responsible for opening the material and for keeping track of hemodynamics. And 1 is the anesthetist. Of course, that's not a real anesthetist or an anesthesia nurse. It's just a nurse that also works in the cath lab. And then as drugs, we don't do any sedation. We give fentanyl, which is just an analgesic. It's not sedative, usually 50 mics. So pretty much what you do for a coronary angiogram. And then we do give protamine after TAVI to avoid or minimize the risk for bleeding. Of course, if we do concomitant PCI, we try not to give protamine, but I would say 70–80% of patients, they do receive protamine after TAVI. And this has been shown to be safe also by a recent publication in JACC Intervention. So post-procedure, you need 2 nurses. Of course, 1 is enough, but she has to take a break as well. So 2 nurses are looking after the patient just outside the cath lab, and they actually do not have special training. Now, I mean, this concept is very attractive, but there is many countries, and Germany, for example, is one of them. They have much more regulation, and for example, you're not allowed to do TAVI without an anesthetist in the room, but in Switzerland, we don't have that. But I think I'm aware that the generalizability of this concept is a little bit limited. So this is our setup, and this was actually the first patient who underwent TAVI with the lean protocol, and you can see the team here, and everybody has a function here, and this is really all the staff that the patient will see during the first 24 hours, and I think that's really quite a lean approach. And also the patient wanted to be on this picture, of course. And I put here the word empowerment. It's also a word from the lean management concept. You empower your cath lab staff to do things that they actually did not do before. And I think people are quite proud, and you can see that on the picture very well. So let's see if I can continue here. Yeah, so, and then the patient is we are looking after the patient outside the cath lab. We still keep an arterial line for a few hours, but I mean, if the patient is super stable, you could even omit that as well, but it's a very simple setup. And after 4 to 6 hours, the patient is transferred to the ward and then usually stays 2 nights on the ward and is then discharged home. So I would like to present you one example of a patient. This is an 81-year-old patient with severely heavily calcified aortic stenosis, as you can see on this picture, with a quite oval annulus, and we implanted an Evolut in this patient in the cusp overlap view. And let's see if I can go on here. So you can see it's not a perfect cusp overlap view, but it's an areocaudal view. So you actually don't need, if it's an extreme angulation, you don't need to go to perfect areocaudal, but already areo 18, caudal 15 opens up the LVLT nicely, as shown by Chris. And then you can really precisely implant your valve. This was done here, so pre-dilatation, and then start with a really high position and then start opening up the valve gradually. As you can see here, we usually aim for 2 millimeter implantation depth. Maybe sometimes it's 3, sometimes it's 1 millimeter. And then we stay in this projection. We actually don't go to LAO. I think it's not necessary, but probably there are different opinions on that. And here we had a really nice result in this patient. So this is our experience with the lean TAVI cusp overlap technique using Evolut. I show you the result of the first 37 consecutive patients, because I think it's quite interesting. Now almost all were men, and the reason is because we had valve size 34 was used in more than 50%. So the Evolut R34 millimeter was used in more than half of the patients. This is because we treat all our large size valve with the Evolut 34. Now 16 had a right bundle branch block at baseline. You can see the implantation depth with this cusp overlap was 2 ± 1 millimeter, so really reproducible high implantation. We had only 16% with a new or transient left bundle branch block, and one patient had a more than mild, actually moderate PVL. The mean gradient was 7. Duration of hospitalization, total duration, so including the admission before the procedure, was 3 days, and the duration after the procedure was 2 days. Interquartile range 2 to 3, so really narrow here. So most patients were had early discharge. And now what's really interesting with this Evolut series, we had one pacemaker in 37 patients, so it was 2.7%. And of note, 16%, so 6 patients had a complete right bundle branch block at baseline. So I think that's quite remarkable. So we were able to treat 5 out of 6 patients with a right bundle without needing a pacemaker. And I think that's really a game changer. We had 2 major vascular complications and 1 patient had a stroke and unfortunately died, but otherwise there were no major complications. So of course that's a very early series, but it's an exciting, I think overall an exciting concept, and I'm really keen to see where this is going. So in summary, we have seen that this is a patient-centered concept. It appears to be safe, but of course there is more data needed. The concept does reduce the duration of hospitalization, and sorry, sometimes it's not reacting very well here, but it simplifies pre-procedural planning because you don't have to plan anesthesia and ICU for your TAVI patient, so that really makes your life easier, and it does reduce waste, things that you can get rid of, such as patient transport routes and also patient waiting time, and it empowers cath lab nurses and improves the team spirit. Now, what I did not mention, or it's actually mentioned here, it also led to a marked decrease in costs of the procedure. So the overall procedural costs were reduced by 14% or 13%. And if you look at the internal cost, so if you take out the implants, the reduction was even more pronounced. It was actually a reduction by 40% of internal cost. So the lean TAVI concept compared to a standard minimalistic TAVI concept really does further reduce costs and may thus help to mitigate increase in healthcare costs associated with transcatheter procedures. So with that, I would like to thank you for your attention and for the invitation, and I'm happy to join the discussion now. Thank you.
Yeah, thank you so much, Stefan, for this wonderful explanation of the lean concept you have in your hospital. There are a few important questions from the audience, but I think we'll go straight forward first to the last presentation of Kendra, which will probably summarize all these aspects in a nice case review. And then maybe we have at the end of the session a few minutes to discuss the whole concept. So Kendra, please.
All right. Well, thank you. Hopefully this summarizes everything we've been discussing. I'm going to be talking about a specific lean TAVI case. This was just last week, so we'll go ahead and get started. All right, the presentation. This is a 65-year-old female with worsening shortness of breath and lower extremity edema. She has severe bicuspid aortic stenosis with a Sievers 0 valve. She also has atrial fibrillation on Xarelto, moderate mitral regurgitation, moderate to severe tricuspid regurgitation with moderate pulmonary insufficiency, and she's awaiting a knee replacement. She's also obese with a BMI of 34. And she was seen by our heart team, and she was deemed intermediate to high risk. And of course, there is no STS predictive risk of mortality for multi-valve disease. But we were concerned about her rehab potential, as well as, at a minimum, she would need an aortic valve replacement and likely a tricuspid valve repair. So we discussed a little bit about our fast track pathway. And for our patients, they have a preoperative EKG on the morning of their TAVR. And if you look at the timestamp, this is about 7:45 a.m. And so she was one of our first cases in our hybrid cath lab. And it just shows, again, atrial fibrillation. But keep that number in mind, 7:45. Here is her echocardiogram demonstrating severe aortic stenosis with a mean gradient of 60. So very tight valve, and you can see that one of her leaflets is nearly completely fixed. Her annulus measured an area of 565 with a perimeter of 85.3. So very large valve for this young patient. LVOT slightly larger. And here you see her sinus of Valsalva, very elliptical, classic Sievers 0 with an average of 33.8. And her sinotubular junction was relatively normal. Her aorta slightly dilated, but nothing to suggest an aneurysm. Here, sinus heights and coronary heights, all adequate. And you see the spicule of calcium. This raised some concerns for our team. A favorable angle, and you can see our implanter's view and our cusp overlap view, all predetermined by our CT scan. She had large femoral access and appropriate anatomy for cerebral protection. So here's our heart team discussion. She's a Sievers 0 bicuspid. She has bulky annular calcium into the LVOT. So there was concern for paravalvular leak, concern for a risk of annular rupture with a balloon, risk of pacemaker. And so with this large annulus, we were deciding between a 26 S3 Ultra versus a 34 Evolut Pro Plus. Given all these factors, we felt the safer option in this patient was, in fact, the Evolut Pro Plus with predilation with a 20 millimeter true balloon. Our optimized procedure is in a hybrid cath lab. We have nurse-led sedation, so no anesthesiologist, no perfusionist or OR team. We have radial access for cerebral protection. We actually use bilateral femoral arterial access with 2 percloses for the large sheath, and this is done under ultrasound and fluoroscopy guidance. A single venous sheath that we use as our central line, as well as our transvenous pacer, and the fast track pathway with possible same-day discharge. Now, this pathway starts preoperatively. The coordination of the fast track pathway or same-day discharge pathway has to be discussed with the patient and the family well before they get to the lab. So here's our procedure. We start with our BAV with a 20mm balloon. We then proceeded with our cusp overlap technique, where we start with the marker band mid-pigtail. And here you can see our REO projection with our valve still well above the annular plane. We were wanting this valve to descend into the annulus so that we have a nice shallow implant and we avoid any interaction with the conduction system. Here is our REO view with our initial angiogram. You can see we're right at 1 millimeter on the on the non-coronary cusp. If you look in this projection, on the left, we look much deeper. But remember, in cusp overlap technique, you can only assess the non-coronary cusp. So we roll to our LAO view. And here's our LAO view. And now on that non, we look superannular. But remember, it's an optical illusion. So on the left here, I think we are actually probably right about 3, which is our target depth. We do think that this valve will cant, so we were very happy with this position. Our final deployment, we think we ended up about 1 on the non and 3 on the left, which for us was a perfect demonstration with no paravalvular leak and no conduction change. Here is our echocardiogram, and that gradient is now only 7 millimeters of mercury. And as you can see, we have no paravalvular leak. So our optimized care pathway, the cerebral protection is removed in a radial band place. We do deliver protamine to reverse the heparin. The large sheath is removed and closed with the 2 pre-placed perclose devices. We assess rhythm in the hybrid lab. If no significant conduction abnormality, the TVP is removed and the venous line. So all she's left with is a peripheral IV. The final femoral angiogram confirms that we have no dissection, stenosis, or flow-limiting lesions. And the contralateral sheath is removed. Our contralateral arterial sheath is removed. And this patient went directly to our angioplasty recovery center. They can also go to the telemetry floor if they're planned for next day discharge. In her case, she went to angioplasty recovery. Oops. The optimized care pathway for same-day discharge, she has an EKG within 2 hours of arrival. She's flat for 2 hours and then immediately mobilized. Post-TAVR echocardiogram is completed. Discharge instructions are reviewed and the patient care pathway with the care partner. This can be a family member or any other adult who's taking responsibility for taking this patient home. And they're discharged to home within 6 hours if they meet all criteria. So here's her EKG, and here you see the timestamp at approximately 11:45. So we said the first preoperative EKG when she was in preoperative holding was 7:45. By 11:45, we've met all criteria. She still just shows atrial fibrillation, so no new concerning conduction abnormalities. Her echocardiogram is completed, showing a mean gradient of 8. And she's discharged by 3:30 that afternoon to her family. Now, we do have a televisit the very next morning from their home, and any patient with any concerning features is recommended to come to our clinic. However, we had no patients readmitted in the series that was mentioned earlier. And so we do believe that this is an effective pathway to fast-track patients safely. Thank you.
Yeah, thank you very much, Kendra, for this wonderful demonstration. of the pathways you use in your hospital. This was a very interesting case. I think also there are a lot of aspects to learn and discuss. So let me first start with an announcement because, I mean, you showed an Evolut Pro Plus, which you fortunately have in the United States and we don't have in Europe yet. But as I understood, that Europe is expecting to have the Pro Plus by the end of next month. I'll go back to you for a few questions. I mean, the audience is very active and we have a lot of very interesting questions. We will not be able to cover all of them, but at least a few. So let me start by one question to Stefan. I mean, it looks like many centers have developed now their best lean TAVI pathways. But at the same time, and we've seen here like three different possibilities from three different centers, the pathways, they do vary a little bit. So I've seen that you are using a temporary pacemaker. Chris is not using one. Chris is using the radial approach or the radial axis as a contralateral axis, and Kendra is still using a bifemoral axis. So do you think that we should standardize these efficiencies in Europe or globally? Do we need to do this? And if we need to do this, how should we be implementing this?
Yeah, I mean, very interesting question. I think, you know, what we have seen, I think from these three examples, these are all very advanced centers. And I think a lot of centers, actually, they still have general anesthesia for all the TAVI programs. I've proctored a lot in different countries, and I'm surprised that even high volume centers they still do cut downs in most patients. They still use general anesthesia for TAVI. And I think at the end of the day, whatever works for your center is a good program. And I think we should not interfere too much with the individual practices. So if people feel comfortable using two femoral access, that's fine. If someone wants to use the radial, that's fine. If someone wants to use wire pacing, that's also good. I think it's more the general concept should be to bring the use of resources down, and at the end, I feel that it will be quite similar to an angiogram. So maybe that what Kendra showing is coming the most close to this already. But on the other hand, you should not compromise on safety. And that's why this super aggressive early discharge, at least in Switzerland, I can only speak for Switzerland, it's not a patient need, it's more a physician and hospital need. So the patients actually, they say, please don't discharge me too early, or the wife tells me, please don't let him go too early home, and so on and so forth. So I think pushing there, personally for me, I think is not a priority.
Yeah,
I don't know if
I agree. I agree totally with you, Stefan, because I think it's very specific or it's very different among different countries. So in Germany, it's very similar to Switzerland. The patients wouldn't like to go home the same day. It's very different in other countries, in the United States, maybe in the UK. Chris, there's one interesting question. I mean, of course, it's important to consider safety. And so the question is really, how far should we push this lean concept? And should we try to push it even further in the current pandemic situations? What is your take on that?
Hi, thanks for letting me back in. I mean, I think the three pathways we've seen have a lot of similarities, but it's clear that they're all still evolving. And in some aspects, you know, some pathways have evolved just by necessity, by COVID, and some have evolved because resource, you know, perhaps in the UK, resource and costs were driving a lean, minimally invasive approach long before COVID came. I think operators and centres have to be comfortable with what they do, and they have to audit how they do, and they have to be given the opportunity to reflect on it. There's nothing that we do that we're not completely comfortable with. I think we all recognize that there are some cases that you just can't treat like a routine lean case, and you do need support and escalation, and you need to build in extra techniques. That's the experience of the implanting heart team. But if you're comfortable with your approach, if all operators are bought in, if the institution has bought into it, then I don't think there's any problem. I'm comfortable and proud to talk about our pathway because it's brought down harm, it's brought down both costs, and it's improved patient outcome with no sacrifice in safety. And certainly when COVID came a year ago, we were actually perfectly positioned to deal with the short hospital requirements, and indeed a lot of the work that our surgeons couldn't do because of critical care occupancy, whereas we were not touching critical care at all, no anesthesia, so we were able to take in the work that the surgeons were unable to do.
Okay, Chris, yeah, thank you. So we have 1 minute left, so one very quick question, quick answer, Kendra. A specific question, as you mentioned that anesthesiologists are not in the room, do patients need preoperative evaluation by anesthesiologists in your center or not anymore?
We don't need it anymore for TAVR. If we are going to have a MAC case or a general anesthesia case, then they go down that more traditional surgical pathway.
Okay, thank you so much. I think we learned, I personally learned a lot from this very interesting discussion. You've seen 3 different pathways, all aiming at the same, on simplifying procedures, streamlining procedures, but the conclusion of the 4 of us is that it's important to do, but it shouldn't come at the cost of patient safety. So thank you so much, and hope you enjoy the rest of the day. Thank you.